Our next speaker is Dr. Ashima Gulati. Dr. Gulati is a pediatric nephrologist with research interest in inherited kidney diseases, with a particular focus on polycystic kidney disease. Dr. Gulati trained at the Yale School of Medicine, where she also completed a PhD in investigative medicine. Her research focuses on human exosome-based investigation of kidney disease and diseases and using preclinical disease model for investigating disease mechanisms in autosomal recessive polycystic kidney disease. Dr. Gulati's clinical interests include the integration of genetic knowledge to improve the well-being of children and with polycystic and inherited kidney diseases. Please welcome Dr. Gulati.
Thank you for the kind introduction and almost good afternoon. I'm excited to be here because this is the last but not the least important talk, and we'll talk about children with PKD. I think as a PKD-focused pediatric nephrologist, when I sit in the clinic, and most of my clinic population is, almost all of my clinic population are children who have some kind of a cyst in the kidney. And when you have a cyst in the kidney, you get referred to my clinic. And the number one diagnosis that I see in that population is ADPKD. And nothing to disclose. And the number one diagnosis is ADPKD, not because we don't have other causes of cystic kidney diseases in children, but because ADPKD is the most common. And talking specifically about polycystic kidney disease, and this is a well-informed audience, there are two types, the autosomal dominant and the autosomal recessive. And the dominant is much more common, we know that, and today's talk will talk about autosomal dominant polycystic kidney disease, but I'm happy to take any questions about ARPKD as well. So why do we need to just talk about these two as very distinct forms, although there've been studies are there interlinking mechanisms, pathomechanisms, or pathophysiology, but just on the clinical face of it, these are two different distinct forms of PKD. ADPKD having a totally different gene defect, totally different proteins involved, ARPKD having a different gene called PKHD1 and a different, similarly sounding but very different protein fibrocystin. So just by the gene and the protein defect and how these two diseases mostly present, they are very different. So it's important to recognize that these as two separate entities. And talking mostly about the pediatric issues in autosomal dominant polycystic kidney disease, I think it's important to touch briefly upon what's the diagnosis, how does the diagnosis look like in children, because we know that kidney failure or advanced kidney disease does not manifest in children with ADPKD. What's the significance of blood pressure control, and how should a follow-up assessment in children look like with ADPKD? There is less clarity on if all children with ADPKD or all children at risk for ADPKD, should they even see a pediatric nephrologist, and what are those, what is that gray zone, and what does that look like, and what should be done? And then are there other complications or other things that we can address in this population? I think we are fortunate that we have some more tangible and very clear guidelines now, specifically focused on ADPKD, with an entire chapter dedicated to children with ADPKD. And the KDOKI, or the Quality Initiative in the US, has a commentary on the KDIGO guidelines, the internationally accepted guidelines, and talking about some of the specifics of how different things can be managed in children with ADPKD. So I think these are very good resources. Talking specifically about the diagnosis, why do we worry about, when we're talking about ADPKD, we still want to touch upon ARPKD, and that's because there could possibly be a phenotypic overlap in certain situations. And though, as I said, it's very different presentation-wise, different genes, different proteins, but when you are looking at a small infant or a child with ADPKD, you always, as a pediatric nephrologist, need to question yourself and say, is this ADPKD for sure? And that is because a very small proportion of ADPKD will present very early in life. And this is not just like finding by screening ultrasound. This is clinically apparent or clinically presenting ADPKD with some kind of a severe presentation. And ARPKD, as we know, mostly presents as a more severe presentation in the fetal life or as an infant. And so there can be some overlap. And so even when I'm doing prenatal consults with the fetus having bilateral kidney cysts, ADPKD is always one of the differentials in addition to ARPKD. And then on the corollary, there will be a very small proportion of ARPKD individuals who have very mild disease and may be confused as having some other kind of polycystic kidney disease. So there is definitely a possibility of overlap. The diagnosis of ADPKD in children, I think it can be divided into two categories. One is, the typical asymptomatic form, which is the most common form that we see. And this is when children are at risk. We know that they are at risk because of the family history, and then we tend to find out because we wanted to find out, or they come to the ER or have another medical intervention or interaction for some other reason, and incidentally you find out that they have bilateral kidney cysts, and that's the typical, and that was not the problem that they presented with. So the typical asymptomatic form is the most common form. But then, as we said, there is a very small, about 2% of all ADPKD can present as a very early or early onset symptomatic or severe cystic kidney disease. And that is something that will come to clinical attention much early. And so that is a very distinct entity that, a pediatric nephrologist would see. And that's an entity which obviously cannot be missed and needs to be accurately diagnosed, not to be confused with ARPKD, because management implications are very different in early onset, say a neonate presenting with ADPKD versus ARPKD. So there are very separate management implications. So that's something that needs to be recognized. And in such situations, genetic testing is particularly useful, especially in early presenting PKD. Or if there is an absence of family history. So what about making the diagnosis by choice? Children who are at risk for ADPKD, but due to a family history, and whether all those kids should be screened and when to screen and how to screen. And I will tell you that this has been a kind of a gray or a controversial or a less, consensus area traditionally. I think we have some more guidance from the 2025 guidelines, but all in all, I think there is a heavy share of responsibility both on the providers and the families to make that joint decision of screening. And the provider's responsibility is to present all the knowledge and to talk about what the screening modalities are. I think it's been traditionally a gray zone and continues to be, a kind of a little bit gray zone, because currently we don't have any validated stratification models to identify children who are at risk for rapid progression in ADPKD. And there are no approved therapies for children with ADPKD, because if that was the case, then we would be finding out for sure. And the other, things to consider are that ultrasound, which is our to-go modality for finding about kidney cysts, the first modality to see if you have kidney cyst or not in a child. If you have a negative imaging in a child, that does not definitively exclude ADPKD, because kids can develop cysts over time. And so the utility of having one negative ultrasound imaging may not be the answer. Genetic testing specifically for ADPKD genes can be definitive, but again, how the genetic results are interpreted and what we find when we do genetic testing for PKD1 and PKD2, we can only say a 100% certainty, or that, is this positive, is this result negative, when the familial variant is known. If the familial variant is not known, there can be a situation where you could still find yourself in an inconclusive situation. And nevertheless, again, any genetic testing, especially in the pediatric population, has, additional social, ethical, and also maybe legal implications. So it's a careful test that needs to be carefully evaluated and not being offered just like that. So what is the KDIGO 2025 guidelines? What do they support? They support or advocate a shared decision-making model. And, shared decision-making model in pediatrics is a well-accepted model. We use it for so many different, conditions. But all in all, what it means is that it puts needs to be a conversation between the physician and the parent or the guardian. And also there is a recommendation to include the mature child if possible. KDIGO doesn't say what a mature child would mean, but it would be different in some situations. But usually the age of 7 to 8 is like the age of assent, and how kids can start participating. And again, it depends development-wise whether, so it would be very different in situation. But if the mature child can participate, then that would be the team who would be discussing that, whether to find or not to find, and then to discuss the screening strategies. And most of those screening strategies would be ultrasound and or genetic testing. And we said that negative imaging is not definitive at one point in time, and genetic testing can have additional implications. So all of that is a discussion. And then to find out, because then if you do a negative, and if you are negative for that genetic test of that for that familial variant, you definitely relieve that anxiety and you are ruling out a diagnosis. So that can be valuable to some families. And if you find out that you have a certain conditions, then you could have, more opportunities for registry participation, clinical trial participation. And then there is an opportunity for lifestyle changes, blood pressure management, which can sound very mundane, but I think it's like a very big opportunity piece that we have in pediatrics. But then there can be additional psychological burden. Sometimes the burden can be of that anxiety of not finding out. And some families may have a higher burden of just like finding out. And inconclusive testing, and depending on where you live, what's your, insurability based on your genetic testing. So all of those are things to be considered. So you can imagine this is a kind of a long discussion that needs to be happened, or an informed discussion. And I don't think there is enough guidance to the pediatricians in the country to have that kind of a discussion with all the families. And so depending on if the pediatrician is well equipped to have all these conversations, then I think pediatrician should be the first point of contact for the families to talk about this. And if the pediatrician doesn't have that kind of time or infrastructure or knowledge to talk about it, then I think one visit with the pediatric nephrologist to talk about all this is reasonable. Just to show that the KDIGO 2025 has this entire table about what is the value of early screening and what are the possible complications of early screening. So there are definitely pros and cons that one can look at, but I think it should be an informed decision whether to test or not to test. And, just a quick minute about what genetic testing, what role does genetic testing play in children with ADPKD? When is genetic testing indicated? Genetic testing is so easily available to all, nephrologists and clinicians these days. And so there is, I think it is very convenient to order a genetic test, but it needs to be carefully balanced as to what is the provider expecting, what is the family expecting, so that there are no surprises in the end. And in general, in ADPKD, in children, when there is clinically probable ADPKD, we would typically, for sure do genetic testing if it's like a very severe presentation, very early presentation. So anything out of the ordinary that would be expected for that age-appropriate polycystic kidney disease, or if there is an absence of family history, because there are other causes of cystic kidney diseases or cystic kidney conditions in children. And then almost whenever we are suspecting ARPKD, we will always go and do genetic testing. And ideally, it's done with a genetic counseling session. So just, to say that we should not, that as pediatric nephrologists, we don't jump to genetic testing for all children with ADPKD. But overall, there is more and more move as as knowledge has evolved better, we feel more equipped to talk about these things. And if we have genetic counseling at hand, we are trying to do more and more testing. Management of blood pressure, I think it's something that we talk in adults all the time, in specifically pediatric issues related to ADPKD, and how does blood pressure control factor into all of that. We know that when you have the more severe autosomal recessive kind of polycystic kidney disease, almost all of those kids will have systemic or hypertension or high blood pressure. And a good proportion of children with ADPKD will have high blood pressure. And blood pressure in general is an established but modifiable risk factor in CKD in children. We have studies not specifically in ADPKD in children, but other CKD cohorts in children that shows blood pressure as an established risk factor in CKD. And so I think it makes a lot of sense by evidence and by the pathophysiology that blood pressure needs to be controlled, even in kids with ADPKD. It needs to be picked up. It's something that you don't want to miss, and it should be managed in children with PKD and also at children at risk for ADPKD who are not tested, so they don't know if they have PKD or not. But getting a good blood pressure, which when you go to the pediatrician, making sure that a good blood pressure was done, maintaining a blood pressure log at home, so not to miss any higher blood pressure readings and not to lose that opportunity of the modifiable risk factor control. In terms of what other symptoms and complications could arise in children with ADPKD who have normal kidney function throughout their childhood, we talked about the blood pressure. Then protein leak in the urine is something. There could be a medicine to control it. There could be lifestyle measures to control it. So that is something that is again linked to CKD progression, and so it is one of the other CKD progression delay opportunities with an early diagnosis or finding out early that you have ADPKD. And so testing both blood pressure and urine protein, irrespective of whether you found out or not, so in all children at risk, should definitely be something that is done, even if the family opts for not doing imaging or genetic testing early on. And so there is a lot of, a focus, I think, that we're reliant on education for all this. And, so a lot of information during provider interactions is needed. There are some other real complications that we do see even in the proportion of ADPKD that is quote unquote asymptomatic and was not early presenting, so didn't present in neonatal or early infancy, but children with ADPKD who have normal kidney function are at higher risk for forming stones or urinary tract infections, and sometimes you do see those complications in the clinic. It's not very common to see the complications, but there are definitely kids who need that complication monitoring. And then large dominant cysts, so one of the kidney cysts on one side becoming so large that it needs surgical management. It's a rare complication, but these kind of situations we've handled in conjunction with urology, where the kid had almost one of the cysts was as large as the kidney. And so that is something that to keep in mind, that it's not without complications. And what about the non-kidney manifestations? In adults, we talked a lot about the liver cysts being the most common non-kidney cysts that are present. And in children, non-kidney manifestations are practically non-existent. And so we do not routinely monitor for extrarenal complications in children because they are rare. They're anecdotal. There are case reports, but there isn't, but they're extremely rare. So unnecessary liver imaging is not needed, but what we will do is that because there are other differential diagnoses of having bilateral cysts in the kidneys, and some of those other differential diagnoses of having cyst in the kidney in children also go hand in hand sometimes with liver conditions, especially having fibrosis or other cystic conditions in the liver. And so typically at evaluation, you would do a one-time liver evaluation just to make sure that this is ADPKD and not other hepatorenal fibrocystic disorders. And but typically children will not manifest liver cysts. But it does become a consideration when kids are growing older and approaching 18 years of age, and especially in females, and if they are seeing OBGYN for another hormonal indication and are being prescribed certain agents, and then you want to talk with those providers to see that your liver cyst risk is not modified in any way. And then, talking about other extrarenal complications, I think aneurysm screening is is talked about. And, we, in adults, there are recommendations on the consensus statement as to how, you should do the imaging based on what your risk is. And that risk is heavily dependent on if you have a family history of brain aneurysm in an ADPKD affected individual. In kids, this kind of a complication is practically very rare or non-existent. But if you look at case reports, there is a one-off case report that this happened and, there was an aneurysm. But again, I think it needs to be balanced out. And what I do in the clinic is, without causing unnecessary anxiety around intracranial aneurysm in a population when, most likely we will not see it, but also not to keep them uninformed. At least at one of the interactions you need to, talk about that this is something that we need to watch out for in the future, so that, you're providing information, but also not causing unnecessary anxiety. And I think that interaction turns out to be more useful, not only for the children, but also the affected parent, because sometimes the parent hasn't had, that kind of a conversation with their nephrologist. And then you can, so when you're seeing children with ADPKD, it's actually an opportunity to counsel the entire family, talk to the entire family, and that is valuable. And then, you need to revisit such discussions of extrarenal complications when you're transitioning the patients. So when they are 18, so, the conversations are very different seeing a 3-year-old with ADPKD versus seeing who's an almost 18, because now your risks will be something that you'll be entering adulthood. So having those discussions around the transition of care, again, becomes important for the pediatric nephrologist. And, the guidelines also talk about the pediatric to adult transition of care models and what kind of care models, should be developed. And the PKD Foundation has come up or will be coming up with transition of care document as well. And so there is an emphasis on a very seamless transition, because transition is the age when the kids are entering the adulthood, but that's also the age when they're going to college. And so, it becomes tricky for a PKD pediatric nephrologist to find, a suitable geographically located PKD physician for a kid who will be leaving family, going to college, but is also now an adult. So, and the pediatric to adult transition of care needs to be more timely in ADPKD than in some other maybe chronic kidney conditions, because your management and screening options and, they expand beyond 18 years of age. So it needs to be a very timely kind of a conversation to have. And I think what's been really nice is having these centers of excellence. So we have not only, the pediatric centers, but obviously we have these, adult centers of excellence and in partner clinics. And so I think, the transition of care is much more streamlined since we have these centers and more information on what to do. This is my last slide, and I just wanted to, because, traditionally ADPKD has been thought to be, this is something that is an adult disorder, and ARPKD is like a pediatric PKD. And we know now that that's not the case. And I think we should tap into that opportunity window of seeing when we see the kids early and, all the good diet or the lifestyle modifications and whatever we just heard about. Like if they can happen early and they can happen, something that can be assimilated into everybody's lifestyle early on, I think it will be an invaluable thing to do for our kids with ADPKD. But even when we, as a pediatric nephrologist, when we see prenatal consults, when somebody's pregnant with a fetus and a woman with ADPKD is pregnant with a fetus and the fetus has kidney cyst or some kind of a kidney abnormalities, that can be a very anxiety-provoking situation. But again, thinking about ADPKD specifically and not ARPKD, those are very two different conversations we have with women who say present at 26 weeks, 28 weeks with fetus affected with a cyst with ADPKD. Because even if you see mild radiographic abnormalities in the ADPKD affected fetus with cysts, it's because now we do more ultrasounds. Our techniques are much more sophisticated. We tend to find out about cysts. So mild radiographic abnormalities in the fetus, which are observed during routine follow-up during pregnancy, may not necessarily predict that the child is going to have a severe ADPKD. And that conversation could be different in other syndromic cystic kidney conditions. So it really needs to be on the top of your, differential all the time, so that, you're not inadvertently just prognosticating in a more severe manner than you need to. And when you have severely affected fetus with ADPKD, then there is low amniotic fluid, so it does portend a higher risk for a poor neonatal outcome. But we don't have that kind of a systematic data in ADPKD. We have some in ARPKD to say that what kind of that 1/3 of those kids would require dialysis in the first 3 years of life, but we don't have that kind of a systematic data for ADPKD. So the conversations with those families who are at this crucial stage of deciding what to do in the pregnancy can be very, very, different. And obviously, a normal fetal ultrasound does not rule out ADPKD. So just, saying that, even though we do see ARPKD, ADPKD is always, more common and, something that we see all the time. This is one of the flower and petal picture that was part of one of the ASN posters we did last year, prepared by Krista Wink from our clinical PKD team. And we actually looked at our the kids with ADPKD, and we realized that these kids do have some multidisciplinary needs in terms of not only nephrology care or the complications of which were more kidney related or blood pressure related, but also other CKD risk factors. Some of these kids were overweight, had obesity, or just had some nutrition. The kids who could benefit from nutritional support. And just HbA1c measurement or lipid measurement, just because of their weight management. And so making those kind of risk factor referrals to preventive cardiology department and having a partnership. So that's what we try to do in our clinic, have a partnership with the preventive cardiology department so that we can have a smooth co-management of these kids. And then, having partnership in urology, because, one for time, you have a big cyst that needs to be taken care of. Psychosocial needs in these kids can be very different, and having somebody who they can talk to in the clinic when they're coming to see you because these kids are absorbing conversations about how an adult parent is affected by ADPKD, and they've probably known about their grandparents. So it's a very different kind of a CKD, a population than you would have in a situation where there isn't a genetic component. And so, psychosocial needs can be different. And so there could be a need for multidisciplinary management. And I think the guidelines provide a valuable framework for management discussions in the pediatric kidney clinic. And, the PKD Foundation has these handbooks, and Paul just told me that there was the ARPKD handbook is out or soon to be out, and it's absolutely new, but I'm happy to take any questions.
Hi there, thank you so much for this talk. So before this started, I shared with you that I have 2 kids who are at risk for ADPKD, haven't been diagnosed formally yet. But I'm curious, before going through that process, just at-home care, there was no mention of NSAIDs or anything like that. And I'm wondering if the same guidance that I'm getting basically to take care of myself, if that's just worthwhile to implement for my children. So avoiding NSAIDs, keeping salt low, keeping them super hydrated, et cetera.
So, as the blood pressure and the protein leak in the urine are the only 2 things that we don't want to miss, even if we're not checking the ultrasound or doing genetic testing. The other kind of general lifestyle measures and healthy, diet recommendations, I think, that we need to just, it's a good idea to adopt that. We just need to be careful that we're not kind of overdoing something that we don't need to do, especially with the protein intake in children. We never, say that restrict protein intake because growth is paramount. And so some of those, diet recommendations might look different for kids than for adults. I think sodium, I don't think any nephrologist sees any good in taking more sodium. So I don't see any positive side of defending that. But So yes, most of those, and then avoiding NSAIDs but when you need to take NSAIDs, then how much you can take and how much with hydration, you can still take it, but like with good hydration, any other medications that are not kidney safe, so all these conversations. But I think, in general, those principles do apply.
Ashima, what do you tell parents whose kids are involved in like sports? Like, do you have any limitations that you advise in terms of?
So typically, we would do some ultrasound imaging intermittently and look at the kidney size. Just, an ultrasound-based assessment of the kidney size. And if the kidneys are large, or if there is like one of the cysts is dominant or any worrisome looking, then it would be a slight, but we would typically tell them to get like abdominal support or guard and to avoid contact sports because of the large kidneys. Recommended blood pressure range is good for children with or at risk for ADPKD. For a child at risk, but has not been diagnosed. So blood pressure recommendations, we have in pediatrics, we have blood pressure recommendations based on the demographic parameters that include age, gender, and height. And then we calculate the centiles. And so depending on the gender, the age, and the height, you will have a different centile, and then what centile is good for that particular age. And typically for chronic kidney disease, the lower the blood pressure, the better it is thought. So if you push it below the 50th centile, there is data that CKD progression is delayed more than if you push it below the 75th centile. So anything more than 95th centile is definitely hypertension. So you would imagine that even like having, in chronic kidney disease, typically we would want to push it absolutely below the 90th centile. But there's data if you push it further down, So you can imagine between the 90th and the 50th centile, like pushing the blood pressure, it would mean higher doses of medication, more medications, and that sometimes is practically impossible to achieve in kids, especially when they're up and about and like going to school. And so to strike a middle ground, there is also some data that, you push towards the 75th centile. And that's typically what we do in clinic. So you don't go by just you're not satisfied just like by below the 90th centile, but cannot go below the 50th. So you would just target for somewhere below the 75th centile. But that number could change depending on the age. The tricky part is that the American Academy of Pediatrics flowcharts that we have about like what blood pressure at what centile only gives us the 50th and doesn't give us the 75th. So it's a little bit of calculation, but that's what we typically do in the clinic. And then do you recommend avoidance of NSAIDs? Yes, I think avoidance I do recommend. I cannot say that it's an absolute contraindication. We have situations where a kid with ADPKD gets admitted with appendicitis, and so we do in a controlled way, but we always kind of sit on the head of people and say that just do as little as possible. But I think hydration is the key with NSAIDs. All right, thank you.